Hello everyone, welcome to your online lecture for the pathologies of the wrists and hands and fingers. For the first part of this lecture, we'll spend time on wrist and hand pathologies, and then we'll segue to finger pathologies at the end of this online lecture. I'm Dr. Cosby. Welcome to part 2 of this online lecture. So our first stop is going to be with a Colles fracture. So we can look here, and what we will see is that it's most often a pathology that plagues the distal radio-ulnar joint. In particular, what we see is a fracturing of the radius bone when the patient falls into a Fuchs mechanism. So that would be with the shoulder typically flexed, the elbow extended, the wrist and hand and fingers also extended. We take a load to the hand. We see this oftentimes in football. We see this in wrestling and in soccer. Slide tackles take out the distal radio-ulnar joint. So some of you might be saying, Dr. Cosby, is the ulna ever involved in that? Yeah, and about 50% of patient populations will see both bones actually being fractured. But a true Colles fracture really truly involves a fracture to the distal radius. And so what are the signs and symptoms? You'll see it here. You'll have this deformity. We call this a dinner fork deformity. So in other words, imagine a world where you put the teeth of the fork down on the table. Hopefully you're seeing that or doing that with me. You will see what we call is a dinner fork deformity. And so what traditionally happens is as the radius is fractured, it fractures towards the palmar side of the hand. And so you'll see you'll have a palpable deformity of the radial head on the palmar aspect of the hand. So what do we do with all fractures? You're right. Yes, we're going to splint it and we're going to refer it. Of course, making sure before we splint and after we splint, we monitor pulse, motor, and sensation, making sure that patients have all of those intact. The great thing about a Colles fracture is they typically will heal themselves and be fully aligned within 1 to 2 months of being in a cast. In other words, there isn't a huge percent of patients who go on to have a malalignment or a non-union at this joint. So that's extremely encouraging. As I said, a Colles fracture really involves the radius. However, in 50% of the patient populations, it's going to involve the ulna. And the biggest concern about whether or not it actually involves the ulna is actually damage to the triangular fibrocartilage complex. So if you think about this, it makes the Colles fracture more complex when you have the ulna involved. We're not necessarily worried about the fracture to the ulna as much as we're worried about the amount of instability that gets created at the wrist because the triangular fibrocartilage complex is compromised. Remember, if we were to go back to that online lecture for anatomy, one of the things that we know about the triangular fibrocartilage complex, if I did a good job, is that it creates a massive amount of stability on the medial side of the hand, right? It kind of contains that articular disc and reduces some of the force and shock that is coming through the medial side of the wrist and will create massive amounts of instability. So when we have a Colles fracture, what we call is a complicated Colles fracture that involves both the radius and the ulna, after it heals, there's lots of rehab for the medial side of the wrist to improve the triangular fibrocartilage complex. In fact, if it's damaged while they're in there kind of resetting the radius and ulna, they'll go in and restore some of the ligamentous stability of the triangular fibrocartilage, therefore kind of increasing the length of time that it might actually take to recover. Now, if we look on this side, oftentimes what we're going to see is a Colles fracture, right? So this is where that radius is going to fracture towards the palmar side. But in a subset of populations, sometimes they land in what we call as a flexed moment. So they don't have a Fuchs moment, but they have almost a Fuchs moment where the shoulder is flexed, the elbow is extended, but maybe they land with the wrist and fingers and hand in a flex moment. And so they suffer from what we call is a Smith's fracture. And so a Smith's fracture is very similar to a Colles fracture in that it involves the same bone, the radius. So we have a fracture to the radius, but what do we note? The radius is actually going to do what? Shift dorsally on the hand. So those are the major differences. Smith's fractures are extremely rare. Again, you're landing in an awkward flex moment, and so then the radius fractures from too much kind of pressure or force in that particular area, but Colles themselves are most common. Next up, here's an example of a fracture to the distal radius. So you can see here just a traditional fracture, not a Colles or not a Smith's fracture. We don't have any typical displacement. This can also happen a lot in redundant sports that require the patient to land in a hyperextended moment at the wrist. So you don't have a true displaced fracture like you do in the Colles or Smith, but you start to see a breaking of the bone on the distal portion, most often on the most distal lateral portion of that radius, right? So you can see kind of a fracturing here. The other thing that we can see, this is one of the largest carpal bones. And so you can also see that because of that Fuchs mechanism, we also have a fracturing to the actual scaphoid itself. And this is a beautiful depiction. Remember, we talked about the radiocarpal joint in the anatomy side. So we have the scaphoid here. And then which bone is this? Great. It's the lunate, you might have said. And you can see how those bones directly articulate with the radius, creating what we call is the radiocarpal joint. So hopefully the two PowerPoint or the 2 online lectures are kind of molding themselves. The next pathology that I want to spend a little bit of time on, which is probably more chronic than traumatic, is carpal tunnel syndrome. I will define or give the etiology on the other slide, but let's talk about it here while we're actually visualizing what happens. And let's kind of look at or identify some of the anatomical structures in this image. And I've tried to put an image down here or place an image down here so you can kind of follow along just a little bit, right? And so essentially what we have in this image are some a beautiful depiction of a cross-sectional wrist. So what we have here, right here, can you see that? Is going to be the flexor carpi radialis, okay? And then as we move more medially into this area, this is the flexor pollicis longus. So far, so good. Everybody tracking with me there? Okay, and then what we have are a group of muscles here, 1, 2, 3, 4. These are going to be the flexor digitorum superficialis. How do we know? It's more superficial to the palm side of the hand. And then we have the flexor digitorum profundus, which is going to be deeper, right? So we have the muscles of the flexor digitorum profundus. And what you can't see here is this little white speck, which would then be representative of the median nerve. Now we have here in cross-sectional area the muscles of the hypothenar MNI. So what do we have? Flexor digiti minimi, abductor digiti minimi, opponens digiti minimi. And we have the muscles of the thenar MNI. What are they? Here's our extra credit question for the day. What are the muscles in the thenar MNI? Y'all tell me. Now, if we look at the bones, we can see that this is going to be the pisiform. Right, so we can see that here, and that is extremely and beautifully depicted. And then what, if anybody wants to guesstimate what these bones are down here, I will give extra credit for that too. If not, we will discuss it in class. I just want to see if you can take cross-sectional anatomy and really truly kind of look at the different rows and different layers. But again, this is the pisiform, so here's your starting space, right? But what are the other bones that are depicted in this image? I'm curious to see if you all know. So as we look at the carpal tunnel, we know that it's this area right in here, right, which is going to be formed by the carpal bones, the flexor retinaculum more palmarly, right? And then we have the flexor digitorum profundus, the flexor digitorum superficialis. We have the median nerve, and then the flexor pollicis longus tendon. And in here, oftentimes what we see is there's either a compressional moment, repetitive flexion, wrist flexion, and finger flexion, which compresses the median nerve. The other thing that you can see is that sometimes you'll get a tractional moment. So if you have lots of wrist extension occurring, you can oftentimes stretch this unit. And essentially what happens is we cause an irritation, a pinching, a squeezing of the median nerve. And this is most often accredited to overuse of the flexors. So wrist flexors and finger flexors, but certainly could be as a result of tractional moments as well. We think about the carpal tunnel, right? And we've kind of talked about this a lot already. We know that it contains the four flexor digitorum superficialis, the 4 profundus muscles, and the flexor pollicis longus, and then we have the median nerve itself. And then we know that the tunnel itself is going to be formed by, here's the hint, some of the bones in our some of the carpal bones, right? And so I want y'all to tell me what those are. I'm curious to see if you actually remember and if you can actually identify them. That's the same extra credit as on the other slide. So if we get any type of swelling, any type of compression in here, just remember there's not enough room, right? And then we have kind of this ceiling formed by retinaculum. We know that retinaculum just doesn't have as much give, and so that swelling starts to compress on the median nerve itself. So what are the signs and symptoms of a carpal tunnel? Well, of course, because it's going to be neural driven, then we know that that patient is going to present with some type of numbness and tingling. And that most often can be into digits. We're going to go with 1 through part of 4, right? The most, we'll say, lateral portion of the ring finger. They're going to have pain with wrist flexion, which may exacerbate the neural signs and symptoms because we'll be compressing the median nerve, right? Now, one of the things that we know is patients who suffer from carpal tunnel syndrome, if they also have rheumatoid arthritis or diabetes, which typically will increase swelling within the joints, then we also see increase in the signs and symptoms of carpal tunnel. So in your history question, some of the things that we want to be thinking about and asking is, do they have a history of arthritis? Are they diabetic, right? Because those are all going to increase the signs and symptoms associated with carpal tunnel. So special tests that we can do, we'll do these in class, but one is Phalings and the other is Tenels, right? We're going to tap right over this, or we're going to force the wrist into a flexion moment and make them stay there for a while to see if we get those neurological signs and symptoms. Now, what is the treatment for carpal tunnel? Man, the jury's still out on this. The evidence suggests a few different things. Night splinting or splinting the wrist in a neutral position to take load off of the flexors, so the median nerve isn't compressed. Oral steroids, I've oftentimes seen direct injections into the carpal tunnel itself. One of the things that we see oftentimes is because this is such a superficial area, so that patients may have an adverse reaction to the corticosteroid injection. And so most often oral steroids are the preferred method to treat the inflammation associated with that. And then we can talk through nerve flossing, but stretching of the nerve and getting the nerve to move within the tunnel most often will relieve some of the signs and symptoms. And I'll have pictures of these to come, but sometimes mobilization of the bones and kind of increasing kind of the tunnel size per se is a good way to kind of unload that nerve. Now, if none of these conservative treatments work, right? Because the reality is this is a chronic pathology. We see this a lot in patients who do a lot of typing or sitting in poor ergonomic positions, right? We're going to see that a lot. See it a lot in patients who gain unexpected weight quickly over time. That weight typically will drop to the wrist and start to compress the median nerve. So you can go in and you can do what's called an aspiration, but most often what they do is a surgical release or a fasciotomy, which is they kind of cut through the fascia to allow that space to open up again. And I think I have that on the next slide. So here it is. So essentially what you look at when I talk about surgical fasciotomies, as you can see here, what they're doing is what we call as a standard release, where they will either come down and literally cut the transverse carpal ligament, and that's released, and it opens up the carpal tunnel just a tad bit, right? So these are your options of release in terms of indication. So who would be a good patient for this? Patients who have had signs and symptoms for more than a month. Those signs and symptoms aren't relieved. Muscles in the base of the palm, so particularly the thenar imini, right, group, or even hypothenar imini group start to what am I thinking? They tend to get smaller. I'm blanking on the medical term, but they get smaller over time, right? So they start to shrink. And so we're concerned because that means they're not getting enough neural input to fire, right? Or to contract and to hypertrophy. And so that they have atrophy. That's what I was looking for. So symptoms occur within 30 seconds of during the Phalen's test, and they're above 50 years of age. If this is a positive checklist, then they are great candidates for this kind of surgical resection or this surgical intervention, right? Now we look at the two different surgeries, and we can see that one occurs a little bit higher on the wrist and one occurs more in the hand. And so this is kind of when we look at the newer types of surgical techniques. The newer types of surgical techniques would be one in which the incision is going to be a little bit smaller. Now, the scary thing is that even if they have the surgery, there's only a 70 to 90% success rate. So we can try it and do something invasive, or we can try to really utilize our conservative treatments to make sure that these patients get better over time. So in terms of surgical intervention, you can look at the different scars that are going to be present, right? And so your endoscopic mini release is on the left, And so then we can see that the standard treatment is on the right in the hand. And I mean, personally, I would prefer a scar that was up here that maybe even wouldn't split or get injured over time, because you're going to be using your hand, right? So all that to say, if we look, you can see some of the muscle atrophy on the on this hand in particular. And then if you look at this hand over here, you can see muscle atrophy on both. So one of the things to consider as we're kind of looking at this is, what do we want for our patients over time? Probably going to have a little bit more atrophy because you're moving into the actual hand space. And so that rehab may take a little bit longer to recover from. Okay, moving back a slide, let's talk through triangular fibrocartilage complex. We already talked through it on the anatomy slide, but a review never hurt anyone. So it's going to consist of the articular disc, which we've talked about down here. And then you have, remember, that ulnar carpal ligament, which is going to be extremely important in, let me find it first, the ulnar kind of we'll call it the meniscus homologue, or the ulnar kind of carpal ligament. And then you're going to have the kind of dorsal palmar and dorsal radial ulnar ligaments, which are all going to kind of work together to kind of create integrity and stability at the actual wrist itself. In addition to that, I should note that we do have the ulnar lunate and the ulnar triquetral ligaments, right? So we have all of these ulnar corporal ligaments, which are all going to be responsible for, they do a couple of things, right? So first and foremost, these maintain the structural stability between the humerus and the ulna and the radius. And then what we also see happening here is it connects the ulna to different aspects of the wrist, since we don't have, like we have on the lateral side, we have that radial carpal joint, right? We don't necessarily have that. So we're creating kind of that sling or that hammock to the carpal bones kind of indirectly through these ligaments, right? We're attaching the lunate to the ulna via this ulnar lunate ligament. We're attaching this triquetral bone to the ulna through the ulnar triquetral lunate, and that creates the stability about the medial side. And so when we have compromise here, when I tell you it's a major stabilizer of the medial side of the wrist, anytime we have compromise to that, then what we see over time is massive instability. One of the beautiful things about the triangular fibrocartilage complex that we see is, because of the ligament stability, it will essentially is a preventer of displacement of the ulna in pronation. So as we pronate, go ahead and put your hand out and pronate far. Imagine if we didn't have that triangular fibrocartilage, that the ulna would just keep coming at our face, right? As we pronate, it would just keep coming. So it's a major restrainer to kind of ulnar dislocation or subluxation over the radius, right? We know that the radius is going to move in pronation. Most often that ulna doesn't do that proximally, and it doesn't do it distally, but the reason for that is the triangular fibrocartilage. Okay. Last but not least, this triangular fibrocartilage complex is also a major stabilizer of the distal radial ulnar joint, because it does contain the palmar and dorsal radial ulnar ligaments. All right. So when we have injury to the triangular fibrocartilage complex, we'll most often see this with a force extension pronational moment, and then with an ulnar deviation. So imagine just waving bye to someone and keeping your hand outward in the bye moment. The other mechanism of injury that we see is a foosh with rotation. So it's not just a foosh. The ulna and radius might be rotating, or the distal forearm might be rotating as well. And so what we'll see oftentimes, especially if there's an ulnar deviation moment, is a compressional moment that happens to the triangular fibrocartilage complex, and that causes injury. So we'll splint like we do with the Colles or a Smith fracture, but if the disc is compromised, or if we have lots of tearing to the different ligaments, so the ulnar lunate ligament, for example, or the ulnar triquetral ligament, or even we'll call it the dorsal radial, dorsal radial ulnar ligament. I don't see the palmar one in here, right here, palmar radial ligament. Palmar radial ulnar ligament. If we have compromise to either of those two, those would need to be replaced as well, because they're going to create the stability between the distal radial ulnar joint. So lots to consider here with a triangular fibrocartilage complex injury. What are the signs and symptoms of it? Great. So that patient, if we think about the signs and symptoms, that patient's going to have massive amounts of pain with ulnar deviation, probably pain with wrist extension moment, right? They might complain, especially if the articular disc is compromised, of like a locking or catching or clicking in the wrist. You will have massive instability when we do glides on the of the ulna across the carpals. They'll have massive amounts of instability, and so we want to assess that. We want to walk them through range of motion. Again, very, very crucial to stability on the medial side of the wrist. Okay, the next pathology that we have is a distal radio-ulnar diastasis. So diastasis meaning spreading of the distal radio-ulnar joint. So again, that happens as a result of a foosh, but it can certainly happen as a result of falling on a hyperpronated forearm. Okay, so you have the wrist extended with rotation of the forearm, and that causes spreading. And so mild would be inferior radial ulnar ligament, moderate would be the ulnar collateral ligament, and then severe would be that you have compromise to the actual disc or the triangular fibrocartilage, right? But in essence, what we also see is this structure here, right? And so even though we have distal radial ulnar diastasis, if we go back here to this image, we have that dorsal radial ulnar ligament, which is going to be responsible for keeping that ligament intact. Then we have the palmar radial ulnar ligament, which is also going to be responsible for keeping that ligament intact. Yes. But as we said, we also have the other ligaments in the group. So that ulnar lunate or that ulnar tricreteral, all of those bones really assist at kind of, all of those ligaments restrain that ulna and keep it in its resting position. So when we go back here and we talk about mild, we're saying, okay, the inferior radial ulnar ligament, which is really what we're saying is the palmar radial ulnar ligament. If we're talking about the ulnar collateral ligament itself, what we're really referring to, I'll go back here, is the ulnar tricreteral, maybe even the ulnar lunate, for example, ligaments. And then last but not least, the fibrocartilaginous disc fracture. So let's go back here. Remember, suspended in this area is the triangular fibrocartilage articular disc. So you have compromise to that. As you think about this, as we move from mild, moderate to severe, essentially what we're saying is, going back one slide, that the more ligaments that are involved, which makes sense, the increased severity of the pathology. And when we get to compromising the fibrocartilaginous disc, then that just increases the risk of instability. So what do we often see? Tenderness to palpation on the dorsal aspect of the distal joint. Oftentimes you're going to have swelling in the distal radial ulnar region. They're going to have pain, obviously, with active pronation and supination. And most certainly when we bring the wrist into an extension moment, they're going to have pain too, because what's that going to do? It's going to cause a widening of the distal radial ulnar joint, right? And what can we do for these patients? What special tests could you use? Not on the slide, but what special tests could you use for a diastasis? Great. If you said the squeeze test, that would be a good kind of indicator of whether or not they have a radial ulnar diastasis. The next pathology in the wrist that we're going to talk about is a scaphoid fracture. The scaphoid fracture, remember, the scaphoid lives in the anatomical snuff box, most often caused by a foosh, usually with some type of radial deviation. That scaphoid becomes compressed between the radius and the second row of carpal bones. And so then it fractures and it gives way. The hard part is, if remember in the anatomy slide, we talked a lot about radial and ulnar arteries and how they come down to kind of supply the carpals and then the fingers. And so one of the things that you're seeing here is the indirect way in which the radial nerve kind of bypasses the scaphoid, right? Like the major artery itself will wrap itself around that first metacarpal, right? You see that there, but it really bypasses the carpals in general. And so we have this little tiny artery coming in to supply that scaphoid. And so what we see oftentimes is these fractures suffer from malunions or non-unions because there just isn't enough blood flow to supply it and to help it thrive and grow. So what do we see in scaphoid fractures? Swelling in the snuff box region, okay, or the outcropping of 3 region, severe pain in that anatomical snuff box. Tenderness to palpation, pain with radial deviation is what I would add in there. So what do we do for patients who maybe have that Fuchs mechanism with a radial deviation moment? We're going to refer them out for an x-ray, and most often they'll do that prior to casting, and then they'll typically be immobilized for about 6 weeks, and that's when then we start strengthening, right? Because again, what we're really worried about is atrophy, typically atrophy of the thenar and hypothenar muscles, and so after that, after they come out of the splint, the biggest thing is then to kind of protect them from motions that might impact them, right? So anything that would be like a Fuchs-like mechanism, we want to avoid for about 3 months. Now, I said that scaphoid fractures have a high kind of non-union rate, right? And so we have to be careful. What we know about the rate of non-union is that it increases with age. And there's something to be said about the overactivity of older patients and the inability to maybe follow some of the guidelines. And so they typically suffer from increase in non-union rates when compared to their younger counterparts. Moving forward, let's take a look at that anatomy so we can see, right? We have the outcropping of 3 here, which we're getting ready to talk about in just a second. And then we have that beautiful scaphoid there, right? And so when we have and then what do we see here? The radial artery kind of wrapping itself around that first metacarpal. And then we like very little blood flow to the scaphoid region in and of itself, right? And so then what do we do for them when we have a fracture? We do what's called an open reduction internal fixation, aka we put a screw or 2 and allow that baby to heal itself. Yes. Now this image is beautiful because we can tell that this is a youth, because we can still see, do you see the growth plates on this particular patient? We can still see them. They're not completely 100% healed as of yet. All right, next up is lunate instability. I am surprised at the number of patients that I actually saw with lunate instability. But what we typically will see is a Fuchs mechanism. So we fall on an outstretched hand, we load, the radius compresses the ulna, and that ulna will kind of dive like palmarly. And so then what that does is the ulna is really suspended by, remember we called them intercarpal ligaments. Those intercarpal ligaments get stretched. And so that ulna, that lunate is allowed to move more often. The lunate continues anteriorly into the carpal tunnel. And so then oftentimes what we can see is if it's allowed to transition too much anteriorly, it can compress on the median nerve and cause secondary carpal tunnel signs and symptoms. It can cause changes in sensory at digits 1 and digits 2. And so this is a concern. So anytime we have lunate instability, yes, we're concerned about a carpal bone that's moving a lot, but what we're really concerned about, because of its position in the hand, is its ability to translate anteriorly far enough to compress on that median nerve. And so a lot of times what we'll see is in the Fuchs mechanism, if we load and that lunate is allowed to transfer forward or anteriorly, we can oftentimes, because there's so many intercarpal ligaments, we can have damage to multiple ligaments, causing instability at multiple carpal bones, but most often you'll get scaphoid and lunate instability if there's multiple ligaments involved. So what are the signs and symptoms? Pain's typically exacerbated by activities like typing or gripping or push-ups. Patient's going to report instability in the central portion of the wrist with some of the activities. And then one other thing that we can do is look at what's called the positive Murphy sign. So if we look at our wrist and we look at the third knuckle right now, it's prominent, right? You can see it kind of bowing more forward when compared to the other knuckles. And so when you make a fist, if that lunate isn't in position, that metacarpal can kind of translate more proximally, and you'll see that there's a third knuckle alignment. So that would be a positive if that third knuckle is in alignment with the other 2 and 4. So one quick thing that you can do to assess, but not the only thing. The other thing that I'll show you in class is kind of how to mobilize that and really truly see how much laxity or instability we have. And so then we talk about how to treat a lunate instability. It's all about providing symptom relief. Oftentimes we will mobilize kind of the palmar side to push the lunate back into its dorsal position in hopes that the ligaments will tack back down or shorten or shrink and allow that lunate to sit where it's actually supposed to sit. So you can do that with wrist control, but if not, you can surgically intervene and in some ways use one of the opponent's tendons to kind of put the sling back in place surgically, right? Surgical surgery is only recommended if there's massive amounts of ligament damage, right? So during the hyperextension moment, if we were to rupture several intercarpal ligaments, then surgery might be indicated. And then you would do kind of a ligament repair, but you can also do carpal fusion, and that would be, I'd say, later phases, unless of course there's a crush injury to the actual hand itself. So what are some treatments? Lunotriquetral, which means you are mobbing the lunate and triquetral bone. But this is a particular ballottement test. So you're going to stabilize the lunate while gliding the triquetrum anterior to posterior. And if you dislocate the lunate, if you're able to dislocate the lunate, that would be a positive, right? So any instability that you would have at the lunotriquetral joint, if you could really feel like an audible dislocation of the lunate, then you know that that intercarpal ligament, the lunotriquetral ligament, is compromised. Okay, the next pathology is an interesting pathology, the hook of the hamate. The hook of the hamate, as you can see, kind of here, we can see that the hamate is a large bone, so most often very flat in nature as we look at it dorsally, but then it kind of wraps around and becomes very hook-like, right? So most often this hook-like portion, or this bony projection, can be fractured. Most often it happens from an acute blow, but certainly can happen as a result of chronic trauma to the hypothenar eminence, right? So to the most medial portion of the hand. We see this a lot chronic-wise in golfers, right? Because the golfers are going to be doing a lot of ulnar deviation. If I could say that differently, chronic trauma meaning massive amounts or overuse of ulnar deviation moments, right? And we can think of a few. Golf is going to be most common. Certainly tennis, if you're using a two-handed slice, or you're doing a two-handed kind of forehand, right? We can see it there. And then in baseball, I don't think I need to tell you why, but we see it more often in our sidearm throwers because they tend to spend more time in an ulnar deviation moment. So they're going to be tender to palpation in this area. So I would say palmar side of the medial wrist. They're going to have wrist pain and weakness, most often wrist pain in ulnar deviation moment and inflectional moments, because that's going to compress the hook of the hamate. So what do we do if we have a hook of the hamate fracture? We're going to splint it if we suspect, and then refer, most often surgery, open reduction, internal fixation. If we just think, oh, it's a contusion, they took a blow, then we protect it with a donut and then unload the area as much as is possible. So let's talk finger pathologies. The first finger pathology that's really common that we see oftentimes in soccer is going to be what we call is gamekeeper's thumb. Remember, we talked about the thumbs having those collateral, all of the digits having these collateral ligaments, right? So what happens is the thumb is forced into an abduction moment. We see this most often in soccer athletes, goalies in particular, as they're kind of catching the ball, but it certainly can happen in other sports as well. But the thumb is then going to be forced into like an abduction moment, and it causes a sprain of the collateral ligament, right? So that patient, if we think about collateral ligament sprains, their major job is to hold a joint to a joint. In this particular case, it's going to hold the metacarpal to the phalanx, right? And so when we have an abduction moment, an extreme abduction moment, we disrupt that ulnar collateral ligament. And so they're going to have pain and instability when we passively abduct that thumb. And then one thing we do is a snap test. If we have a ruptured ulnar collateral ligament, they will be unable to snap, or at least not be able to snap as forcefully when compared to the other side. So what do we do for these patients? It depends. A grade 1, we're going to treat symptomatically. A grade 2, right? Remember, there's tearing of the fibers, will immobilize, maybe create orthoplast splints, which you all learned in ATR 6090. And then grade 3 would be a complete rupturing, and so we would actually have to surgically repair that. So it really just depends. Again, we see this most often gamekeepers. Does that make sense? Goalie, right? So we see this most often in goalies when they're trying to catch balls that are coming at very high velocities. Next is a Bennett's fracture. You can see it here on this image. It is a fracture of the first kind of carpal, metacarpal joint in particular. And so what we can see is it may or may not extend into the articular surface and then into the trapezium itself. Most often, though, it is a fracturing of that first, you see it here, metacarpal, proximal metacarpal. It occurs most often as a result of like an axial load or blunt trauma. So like you take a blow to the tip of the thumb, maybe you're boxing and take a force to the thumb itself. So those would be the common ways that we typically, in terms of actually treating it, the only way to treat a Bennett's fracture is through some type of either internal fixation. You can do an external fixation, which means you have pins kind of coming out of the hand, but most often it's going to be an internal fixation. Again, if we look at the Bennett's fracture, we can see that there's a fracture to the actual, the most proximal portion of the metacarpal. But what most literature will say is that it extends into that kind of carpal metacarpal space, creating what we call as an intra-articular kind of fracture. It may also then fracture off a piece of the trapezium, which would be the bone that kind of sits kind of right proximal to that. So very complicated fracture that should definitely be assessed right away and then referred for surgery if in fact we do have a fracture. Okay, in general, we have finger fractures and dislocations. Most often a finger fracture is going, and dislocations really are going to be a result of some type of crushing blow, a longitudinal compression, rotation, or a blow to the tip, right? So anything that would be like acute traumatic to the tip of the finger can cause a finger fracture or a finger dislocation. Fractures are most common in the distal phalanx. That makes sense. It's going to be the first point of contact. It's going to absorb most of the force. Great thing that you can rest assured of is most of the trauma does not occur to the middle phalanx. It's long, and so it's capable, it's resilient of transferring the forces. So you have the short distal phalanx, which absorbs a lot of the force and is at high risk for fracture. You have this long middle phalanx, which really isn't fractured or dislocated very often. Now we move to the proximal phalanx, right? Most often what we see is a fracture or dislocation with a twisting or rotational force. And that is typically going to be concurrent with like a skin and tendon trauma. In other words, maybe a compound fracture. And so signs and symptoms, patient's going to feel like a pop or a click. They're going to have tenderness and swelling and deformity and maybe even bleeding, depending on if there's kind of an injury to the nail or the skin because it's so superficial there. So what are some of the special tests? We can do a compression test. We can do a tap test or a tuning fork test. Y'all already know that would not be my first choice. In terms of complications with fractures, anytime we have an index or middle finger, you are most likely going to need some type of internal open reduction, internal fixation. And so the reason for that is because of their inability to tolerate angular deformities, right? In other words, these are the two fingers that we're going to use most often, and they provide a lot of the stable portion of stability to the hand. Anytime we have spiral or severely angulated fractures, they become very difficult to kind of put back together. Or if we have a fracture of multiple, so you can see that here, metacarpals, it just makes everything more complicated. And then use low threshold for referral of youth athletes due to growth plates, right? You want me to say that again in a different way? You should always consider referring a youth athlete in the event that you suspect a fracture because they have growth plates, right? And we never know if the fracture is going through the growth plate. And if it does, right, then you all know that we're concerned about whether or not bony growth is going to be impacted. So I would say when you have a youth athlete and you suspect a metacarpal or phalangeal fracture, then we want to refer out just to make sure that the fracture did not go through the growth plate. Again, another way to say this, top one is, no, sorry, going back right here. Another way to say this second one is to say that anytime you have an index and middle finger fracture, refer it, right? Because most often they may need surgical intervention because of their inability to kind of handle angular deformities. In other words, we're loading them more, we're going to be utilizing them more, and so they may need more stability so that the fracture heals and we don't have a malunion or a non-union fracture. Okay, the next is a Flexor Digitorum Profundus rupture. So I love this image down here. we see flexor digitorum superficialis, and we see it splitting, and then we see the flexor digitorum. Do you see it here kind of coming through and then going down to its attachment onto the distal phalanx, right? And so profundus finger, also known as jersey finger, for lack of better words, right? And why was that? Because oftentimes in basketball, athletes would run across an athlete and grab their jersey, and their finger would get stuck, and they would rupture the flexor digitorum profundus, right? Now, in terms of how it actually happens, forced extension at the DIP, when you have like a flexional moment. So that finger is in flexion, but then it gets forced into an extension moment. And as a result, you cause the flexor digitorum profundus to rupture. Now, what do? When you have the patient make a fist, they cannot flex the DIP. So everything will be flexed, all of the fingers will be flexed, and then the finger that has the ruptured flexor digitorum profundus will not be able to flex the dip, and so their dip will be in an extension moment. And so what we want to do for them oftentimes is we want to splint in flexion and then refer. Again, one of the things that we have to think about is our fingers. Remember, they are precision. They allow us to perform precise movements. So when we have a finger pathology, particularly a tendinous rupture, we always just refer out to an orthopedic or a hand surgeon to ensure that everything else is intact. Because if we go back to remember we talked about the flexor and extensor hoods, there are other items in there. Remember we talked about items, collateral ligaments or other cruciate ligaments that help to kind of create that pulley system. So even though we might have an injury to the flexor digitorum profundus, there may be other structures that we don't see that are also compromised, which might impact our actual finger function. So make sure as you're working with patients with finger pathologies that you really do them a good service by referring out. Okay, flexor tendon injuries. So the location of the injury influences recovery after surgery, right? Flexor tendon injuries of the finger are notorious for extended healing and times and complications. And so the areas shown in red are referred to as no man's land. What that means is the stiffness is such a common problem after injury. So if we have an injury, basically you all could tell me this, right? This is an injury below kind of, what would these be? Below the metacarpals, right? So if we're looking at this from a perspective, this is metacarpals, these are going to be phalanges, right? Injuries to the phalanges typically take a very long time to heal because there is such an incredible amount of stiffness in this region. And part of that is because it's so bony and it's so ligamentous that when a patient suffers from this after they recover, they still suffer from an amazing amount of stiffness. The other thing that we've seen in injuries of the phalange is scar tissue buildup, right? And so it will become extremely important for you to kind of consider soft tissue, for example, over that area to reduce the amount of scar tissue buildup in hopes to reduce the amount of stiffness in that particular area. Next is Dupuytren's contracture. You can see that here, indicated here. Essentially what we have are these kind of nodules or adhesions that build up in the palmar fascia of the hand. So remember we talked about that palmar fascia that exists over the muscles, kind of like the plantar fascia. So what you have are these nodules or big, large bumps that develop over the palmar fascia of the hand. And so what happens is as you move into a flexion moment, those nodules kind of your muscles get entrapped within those nodules and you get stuck in a flexion moment. So you'll see that here. You typically will have a flexion contraction of the MCP and sometimes the PIP joint. But you can see here the flexor contractions happening at the MCP joint, and you can see the flexor tendon kind of just popping out at you, and it's probably just stuck within one of those nodules or adhesions, right? This is most common in the fourth or fifth fingers, so most often you're going to see it here in the ring finger or the pinky finger. And then again, older patients are going to suffer from this. This usually isn't a younger patient pathology, and it's going to be more common in men, in Irish, Scottish, Scandinavian, Northern Europe. Not quite sure why. I tried to look, not quite sure why. So again, pathology, we have this fascia over time as we get older. Another thing to look forward to, right, is that we have a development of adhesion where the fascia just sticks really tight to the muscle, or we start to develop nodules within that fascia, right? And so as a result, it causes a contraction of the flexor muscles, or as you go to flex, those muscles get stuck under the adhesion or in the nodule, and your finger, your fourth or fifth ring finger, kind of just stay in a flex moment. And so what do we do for Dupuytren's contracture? What would we do? Anybody? Yeah, the treatment's going to depend on the severity. So oftentimes the physician will kind of go in and maybe cortisone inject into the area. Most often that might work. The other thing, the physician might actually pull the finger out of a flexion moment and splint them into extension, right? That would be another way to think about it. Last but definitely not least, maybe there's some type of like surgical procedure where they might go in and do like kind of a releasing of the fascia in that particular area. The goal would be to treat it as conservatively as possible. So soft tissue, you might go in, if it's a nodule, maybe with a needle biopsy and kind of remove that nodule. So it's really going to depend. Again, unless you're planning on working with older patients, which some of you are, you really won't see this very often. Okay, next is trigger finger. It's kind of similar to Dupuytren's, aka stenosis tenosynovitis. So what is the pathoetiologist of this? So trigger finger, think about it this way. Think about pulling a trigger on a gun. When you do that, what do? You kind of flex your pip and your dip around the actual trigger. So think about it that way. That is the deformity, right? The finger stays in a trigger position. So ultimately, if we think about how this actually develops, it's usually occurs as a result of massive repetitive flexion, particularly at the PIP, maybe even MCP, but definitely the DIP as well. And so what happens is a nodule, just like with Dupuytren's, a little bit different because it's not the palmar fascia. It starts to develop and it causes the tissue to thicken, right? And that nodule typically will occur within the actual tendon itself. So this, we know, if we're looking at it, is the profundus because it's attaching to what? The distal phalanx, right? So we have this development of nodule, right? Remember, we have these ligaments that kind of hold the joints together. So we've got cruciate ligaments here. We have what we call our A1 pulleys that kind of go across the bottom of the joint and also on the dorsal side of the joint as well, but they create the pulley system for the ligament to move through. So as you can see here, if a nodule develops as the patient kind of moves into a flex position, you can see that here, right? The nodule slips past the A1 pulley system and then stays stuck when the patient tries to move into a flex position. It gets stuck, it gets lodged in this A1 pulley system, and so it stays stuck in what we call is a trigger position. Now this is most common in patients with diabetes and rheumatoid arthritis. Part of that is lack of blood flow and fluid moving leads to stasis of fluids and the development of hard nodules within tendinous structures. So what are the signs and symptoms? Painful, like they'll feel like a catching, a clicking, or a popping as that nodule passes through the pulley system. So my dad actually had this last year, and it was so cool to see. I almost wish I would have videoed it. So I would have him flex and extend his finger, and if you were looking on the palmar side, as it was moving through the pulley system, you could just see it like jerk, the pip jerk into a flexion moment once the nodule had kind of pulled through. So, and it's painful, okay? It may lock or become stuck, especially depending on how large the actual nodule it is. And if the large nodule is large enough, you can also palpate it on the palmar side. So what in the world are we going to do for this? So it depends. A couple of things. They tried splinting, they tried night splinting, they tried day splinting, they tried NSAIDs with my dad. We tried soft tissue, we tried like gliding the finger. None of those things worked. They tried cortisone injections, and let me tell you, when I say it's painful, it's painful. You can see it here into the actual tendinous sheath, and that worked for a while. It reduced the swelling, but of course, as soon as he started moving the finger again, the nodule developed. And so then they went into surgical treatment, right? Surgical treatment where they actually kind of help, they kind of remove the actual nodule, and that has worked perfectly over time. But that surgery, just to be clear, can be a very painful one where they are making an incision and splitting the skin and then removing the nodule. But at least now, at least from personal experience, my dad doesn't have the trigger finger sign and symptom any longer. Okay, the next pathology is a Boutonniere deformity of the finger. So you can see the deformity itself. The etiology is most often extreme flexion or some type of crushing blow. The pathology is a rupture of the central slip of the extensor tendon. So this is why it's important when we're thinking about pulley systems, right, and HUDs, that we understand that. So we have a rupturing of the central slip of the extensor mechanism. And so then that patient, a couple things happen with that patient. You're going to have MP, so MCP, metacarpal phalangeal joint extension, which you can see here beautifully. You have flexion of the PIP because you cannot move into an extension position because the extensor mechanism is ruptured. And then you have extension of the DIP. So if you were to rest your index finger on your thumb and push down, that would be a Boutonniere deformity, right? The goal is to get that finger into an extension moment. So we're going to put that patient in an extension splint. And I say it like it's easy. Let me tell you, it's painful, okay? Next is a boxer's fracture, coin boxer's fracture, because we've seen fifth metacarpal fractures most often in our boxers. You all know how fractures happen, particularly to metacarpals. It's direct axial force or some type of compressive load, most often associated with MMA, boxing, martial arts, right, where they're hitting hard objects or people. And so we'll have pain and swelling most often on the most medial side of the hand, right? And you can see that kind of at the metacarpal phalangeal joint. And so in terms of management, we're ricing, we're x-raying, we're splinting for 4 weeks. Most often they don't need to be in a calf. The only time that we're concerned is if there's angulation that happens. So if there's a displaced fracture, so by angulation, you can kind of see that there. Well, they'll have to replace or align the fracture to make it, to ensure that it will heal and align itself perfectly, right? The more proximal the fracture, the more pronounced the deformity. That's because the hand is more superficial, right? And then anytime we have any type of rotation in the fracture site, so this would be an example of rotation, there's no alignment there, then surgery is always going to be indicated. So it's really going to depend. Next is the jam finger or sprain of the collaterals. And that can happen at the DIP or PIP. It's massive loading of an extended finger, right? And I'm sure you all have done that. Fingers extended, ball comes to the tip of the fingers, and we have a sprain of one of the collateral ligaments. So you have this ligamentous sprain. Oftentimes it can be associated with a volar plate rupture or fracture, so make sure you're assessing that as well. But positive varus and valgus stress test, right? Next is DeQuervain's syndrome. Remember we talked about the outcropping of 3. So in the outcropping of 3, you have the extensor pollicis longus, right? You have the extensor pollicis brevis, and then you have the abductor pollicis longus. All are movers of the thumb. The 2 extensors obviously are going to pull the thumb into extension, and then the abductor is going to pull the thumb out into an abduction moment. But essentially what you see with DeQuervain syndrome is repetitive thumb extension abduction in this area causes an inflammatory response, right? So you get this inflammatory response of kind of the synovial sheath that is lining these 3 muscles, right? And so when you have the synovial sheath inflamed, it starts to kind of impinge upon the neural structures, particularly the radial nerve. And so what you'll essentially see in patients who have DeQuervain syndrome most often is numbness and tingling into the thumb most often. And you'll also see a positive Finkelstein. So point your finger down into the pinky, do thumb opposition, wrap your fingers around, and then have the patient ulnarly deviate. This will cause sharp pain. It may cause crepitus, maybe even some neuropathy. And so what do you do for this patient? Reduce the inflammation. So most often oral corticosteroids would be an example of this. And then maybe some corticosteroid injection. And then if that doesn't work, and if the nerve is involved in that, then you'll have to do, you'll actually do surgery and you'll do a release of the synovium to create space. So very similar to carpal tunnel in a different way. Most often these patients don't have the neural signs symptoms unless we allow the inflammatory response to go on and to go on and to go on. Okay, one of the most common types of pathology is a mallet finger. So jersey finger, if you recall, was an injury to what? The flexor digitorum profundus. And so when you made that fist, remember that finger stayed in extension. Now we have mallet finger. Mallet finger is a rupture of the extensor tendon. So you can see that extensor tendon kind of coming down to have an attachment onto that distal phalanx. And so there's a rupture there, right? So this patient is going to present differently. They're going to present with a flexed dip because they won't be able to extend the dip. So that is the major difference between a mallet finger injury and a jersey finger injury. So you have rupture of the extensor tendon, and you're going to splint into extension moment. I'm going to skip the slide and show you. So you're going to splint using what we call as a stack splint. And I'm saying all of this, these are not easy. These are very, very painful splinting techniques, but we want to do this because if we don't, when we go back, one of the things that we're really concerned about is whether or not the patient will regain finger extension. So we really do need to force it. Now, what you're seeing in this image here is most often with an extensor tendon rupture, which we see there, you also have what we call as an avulsion fracture. So typically we want to splint and refer just to make sure we don't have an avulsion fracture. If we do, then they'll still put them in a split, but then what they try to decide is what type of splint to put them in. Next is a Swan-Neck deformity or volar plate rupture. So think about that A1 pulley system. Remember, they kind of support the palmar surface of all of the joints in the phalanges. So in terms of the presentation, the patient will have flexion of the MCP and the DIP. You see that there, flexion there. And then they'll have hyperextension of the PIP, right? And some of us can actually do this. So you get this flexed P, you get this flexed DIP, you get this hyperextended, right? Because there's no A1 pulley system supporting that. So you get this hyperextensive PIP. And then in some ways you get a little bit of a flexion moment in the MCP, right? So what's the pathology? They can be born this way, okay? Or they can have the volar plate rupture, right? That's most often what we see. They have a lax volar plate or they have a volar plate rupture. In addition to that, you can also have where you have a fracture of the middle phalanx, and maybe that middle phalanx drops palmarly, causing that as well. Now, we do tend to see oftentimes patients with rheumatoid arthritis will also have the Swan-Neck deformity. Again, that really is as a result of like a hyper kind of laxity that might exist right here in this A1 pulley system. But this is what a Swan-Neck deformity would look like. Oh my goodness, what would you do for them? Someone tell me. Yeah, you're going to splint it, right? So you can see Swan-Neck deformity here. That beautiful swan neck. You see it? Long swan neck. Everybody got it? So you have that flex DIP, hyperextended PIP, and you get a little bit of flexion at the MCP as well. The next pathology is going to be Handlebar Palsy. Handlebar Palsy, as the name implies, is usually seen in bikers. It's a compression of the ulnar nerve at the tunnel of Guyon or Guyon. So think about it here. So we have this ligament kind of holding two carpal bones together, and then the ulnar nerve is going to come between there. So it's in this sweet spot here that you get compression of the tunnel of Guyon. And so the tunnel of Guyon is formed by the hook of the hamate and then the pisiform bones, right? So we can imagine that this is probably called like a piso-hamate ligament, right? And then you have that tunnel of Guyon coming right here. A better way to look at this is going to be like the flexor retinaculum. And then just above that, you see it here, is the ulnar nerve. Then we have a ligament here holding that hook of the hamate and pisiform together. And so you have that ulnar nerve coming in between there. And the handlebars sit in this sweet spot and start to compress that ulnar nerve. So what are signs and symptoms? Numbness and tingling on the medial side of the hand, kind of going into that ring finger, at least the most medial portion of the ring finger. So lots of paresthesia or anesthesia in that area. All right, I think this is the last slide. It is a wrist ganglia. You can see it here and here. It's a synovial cyst. So we have herniation of the joint capsule or the synovial sheaths kind of surrounding the joint itself. generally appears after a wrist strain, which makes sense. Most often hyperflexion moments where you stretch all of the anatomical structures, and then you see fluid being allowed to come through that actual herniation, right? Dorsal is way more common than palmar or volar, just so you know. And so it's going to present like this. I'll show you something in class. You just slap a book on it, and that usually does the deal. But you can ultrasound, use like therapeutic ultrasound, not real time, to reduce the size. And you can do surgical removal with a repair to the herniation. Because if we remove it and we don't repair the herniation, then guess what? It will come back. All right, y'all, that is the end of the pathology PowerPoint. I will see you all in class on Thursday.